Good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well. Well, here I am at my other job, doing some, I guess you could call it remote clinic work of sorts. I can't really go into the specific details of what I'm doing, but it is, well, it's early in the morning now. It's a little after the witching hour, and I've managed to clean house, so to speak, and I have a little bit of downtime before I have some chores that I need to do, and I need to also make a pharmacy run to pick up some medications here in a couple of hours. But be that as it may, I figured what I would do is just take this opportunity to talk about a rather esoteric subject in terms of dealing with it in the pre-hospital environment. But I think it's an interesting topic. It's certainly relevant. And it's something that is important for us to at least have a cursory appreciation of. And it actually belongs to a larger concept of oncological emergencies, which is, I would dare say, a bit underappreciated in terms of pre-hospital medicine. So this is certainly one of those critical oncological emergencies that does have pretty profound pre-hospital implications associated with it. And the specific subject I want to talk about today is something called tumor lysis syndrome, or TLS. But what is tumor lysis syndrome? Well, tumor lysis syndrome is a syndrome of electrolyte abnormalities and acute kidney injury that is associated with or due to massive cell lysis in a cancer patient. Typically, this is going to be the result of exposure to cytotoxic chemotherapeutic agents, and often this occurs in the first several days of someone beginning cancer treatment with these cytotoxic agents. This has been rarely reported to occur spontaneously in some patients, and there are some other non-directly cytotoxic agents like monoclonal antibodies that have also been associated with tumor lysis syndrome. So what is the presentation of tumor lysis syndrome? Well, the presentation kind of has two major forms. The first form is a kind of subclinical presentation, if you will, where you actually have some laboratory anomalies, but you may not have significant signs and symptoms or overt clinical impacts. And so it can be tricky from a pre-hospital perspective if you don't have access to labs, and that's why eliciting a good history physical exam to potentially obtain that information can be so helpful in many, if not all, pre-hospital care. So the laboratory presentation of tumor lysis syndrome really comes down to hyperkalemia, or elevated potassium, hyperphosphatemia, or an elevation in phosphorus, and then the phosphate tends to bind to and precipitate with calcium ions, and so you have an increase of phosphate but a decrease in serum calcium as that binds and then precipitates out of the blood as calcium phosphate. In addition to that, you have an increase in uric acid and acute kidney injury, so an increase in the BUN and creatinine would be the classic findings. Now, if the initial laboratory anomalies are left untreated, this can then lead to more overt clinical signs and symptoms or clinical impacts, to include nausea and vomiting, lethargy. ECG changes is a big one, particularly T-wave changes, tall peak T waves, seen in the setting of hyperkalemia. Seizures, often due to the hypocalcemia, and even dysrhythmias, potentially life-threatening ventricular dysrhythmias due primarily to the hyperkalemia. So the basic pathophysiology of tumor lysis syndrome really comes down to massive cell lysis. And so you have the contents contained within the cytoplasm and the cytosol of the cell essentially gets released out into the body, and then you have this occurring en masse. And so you have three major things happening. You have lots of potassium being released, because remember, potassium is the primary intracellular cation that gets released, and you have an elevation in serum potassium that goes on to cause ECG anomalies, tall peak T waves, flattened out P waves, loss of the P wave, a widening of the QRS, and the sine wave that we see with the classic changes of life-threatening hyperkalemia, at least from an electrocardiographic standpoint. Now, I should also say that the classic changes associated with hyperkalemia are not always present. The next thing that we have is the nucleus is compromised, and it is releasing nuclear material, ribonucleic acids and deoxyribonucleic acids, RNA and DNA, and through a complex set of steps that are, of course, all enzyme mediated, these nucleic acids are converted into uric acid. And uric acid is poorly soluble. You have to get rid of it primarily through the kidneys, but it's poorly soluble, particularly in the more acidic environment of the renal tubules. And so the uric acid tends to it tends not to be easily eliminated. It stays in the kidneys, and it can cause kidney damage. And it is one of the major parts of the acute kidney injury that we see with tumor lysis syndrome. And then the next major thing that happens is phosphate ions are released from these lysing cells, and these phosphates bind to calcium in your blood, and that forms calcium phosphate. And so you are having a loss of calcium, and that causes a functional, essentially a hypocalcemia, and all of the sequelae of that, the neuromuscular problems that you get, the positive Chavostics and positive Trousseau sign in severe cases of life-threatening hypocalcemia, and that can even lead to seizures and neuromuscular irritability. And the calcium phosphate tends to precipitate out of the blood plasma, and it tends to accumulate in the kidneys, further causing acute kidney injury. So it's really the uric acid and the calcium phosphate ions that are causing the acute kidney injury. So that is the basic pathophysiology of tumor lysis syndrome. What are the major risk factors of tumor lysis syndrome? Well, it's fairly straightforward. Cancers. There are three major types or categories of cancers that are most strongly associated with tumor lysis syndrome, and they include acute lymphoblastic leukemia, or ALL, acute myeloid leukemia, or AML, particularly AML with a markedly elevated white blood count. And often you're going to see white blood counts exceed 25,000. And then non-Hodgkin's lymphoma. In particular, I believe Burkitt's lymphoma is most strongly associated with the risk of tumor lysis syndrome. And in situations where you have an elevated tumor burden and bulky metastatic disease will also increase the risk for tumor lysis syndrome, as well as pre-existing laboratory anomalies that you would expect, such as pre-existing elevation in uric acid, potassium, phosphate, or underlying renal insufficiency is also going to increase the risk of tumor lysis syndrome. So how are we going to manage tumor lysis syndrome from a pre-hospital perspective? Well, it's fairly straightforward if you have a high enough index of suspicion. So that's the most important part of all of this. The linchpin, if you will, the Rosetta Stone for figuring this out is having that Rosetta Stone and understanding making these connections, recent diagnosis of metastatic disease, recently receiving chemotherapy and asking the right questions, like, well, when did you have your chemotherapy? Was this the first treatment? Were you just started on this? What kind of chemotherapeutics were given, if you know? How many days ago was this? And can you kind of establish a causal, a causal relationship, as well as what kind of cancer do you have, and kind of put things together to go, oh, there is a high possibility that this could be tumor lysis syndrome. So that's the first step, is just putting all the pieces together and arriving at TLS as a legitimate differential diagnosis or field diagnosis. And then step 2 is going to be managing the life-threatening manifestations from a pre-hospital perspective, and that's going to revolve around, if you suspect or you have findings suggesting a life-threatening hyperkalemia, initiating hyperkalemia therapy, right? Giving calcium, administering sodium bicarbonate, administering high doses of albuterol, possibly insulin, dextrose therapy if you have the ability to do that as a pre-hospital provider. Step 2 is going to be aggressive IV hydration, right? You want to ensure that you are giving these patients adequate fluid resuscitation to help with the kidneys, to help prevent and attenuate the underlying acute kidney injury that may go on to cause renal failure. And if you have severe or signs and symptoms suggesting severe hypocalcemia, such as the positive Shavastic sign or the positive Trousseau sign, or seizures, again, administering calcium is going to be important, but that should also be an important part of managing the underlying hyperkalemia. And then obviously good, aggressive, overall supportive care to support the ABCs, like we would do on any patient that has any major compromise of their airway, breathing, circulatory, hemodynamic status. Beyond that, there's not much else that we can do from a pre-hospital perspective other than recognize immediate treatments, transport, and then make sure that we communicate our concern and make sure that the receiving providers understand that we have a high index of suspicion for tumor lysis syndrome, because once they get into the hospital, there are some additional therapies that are going to be important. Certain medications that can attenuate or help prevent the accumulation of uric acid or promote the elimination of uric acid. So drugs like allopurinol may play a role, an important role in treating tumor lysis syndrome. Continued aggressive fluid management, in addition to possibly instituting renal replacement therapy while the patient is recovering from their underlying acute kidney injury. So that's tumor lysis syndrome in a nutshell. Hopefully you all found this video helpful, and hopefully this is, if you're a paramedic or a pre-hospital provider, hopefully this has provided you with some vignettes of information that you can now integrate into your clinical practice, and should you run into a situation like this, you will be better prepared to manage that patient appropriately. All right, everyone, take care, and we'll see you all in the next video.